Well, thank you again for the opportunity to share some of this work that we did early on in the pandemic involving surveillance for COVID or SARS-2 in long-term care facilities. And before I start, I should probably disclose that I am not a virologist, nor am I a physician. I'm a clinician scientist. I'm not even an infectious disease expert or an expert in long-term care facilities. So this was sort of a pivot for me in terms of responding to a public health crisis. And we were in a position at CSU at the Center for Healthy Aging to really respond in a way that we hoped was beneficial and helpful to the community. And we have a wonderful relationship with Columbine Health Systems, and we're named after them. And so I did want to acknowledge their just their sponsorship and help in terms of our initial efforts. So I also want to invite to acknowledge two of my co-leads that were part of this this effort. And these guys are really the talent behind it, because these are the infectious disease experts. Greg Ebel, who is the director of the Center for Vector-Borne Infectious Disease here at CSU, and then Christy Pavalonia, who is the director of the Veterinary Diagnostic Laboratory. Their group was really responsible for our success because they were able to pivot their own activities to become CLIA certified and actually begin to participate in helping with the surveillance effort across the state. So I couldn't have done what we did without them, and I think they've been very central to this effort. So I mentioned that the Titanic in the title of my talk, and I think that the public anyway, if you're from the outside, wonders why the toll has been so disproportionately high in long-term care facilities from COVID-19. And you can all remember these very, very inflammatory headlines that were coming out. And this sort of progresses from the beginning of the pandemic. So New York Times in 2020 or April of 2020 about talking about these places being death pits, et cetera, et cetera. And then most recently, New York Times in June saying 1/3 of US coronavirus deaths are linked to nursing homes. So these kinds of titles have really provided the background with which most people have viewed from the outside what was happening in the early days of the pandemic. And yes, it is true that to date, residents in long-term care facilities represent about 33% of the COVID-related deaths in the United States, despite the fact that they represent only about 2% of the US population. But we need to unpack this a little bit more. And so to start with, I think I did, and I think maybe many of you might benefit from a primer about long-term care facilities to understand the climate that all of this has taken place in. So long-term care facilities in general, and again, this is, there are certainly exceptions to this, fall under, typically either nursing homes or assisted living facilities. And a nursing home, what defines typically that is just the need for a higher level of care. So within a nursing home, there are higher levels of medical treatments, medical management assistance, as well as assistance with daily living, including, transferring out of beds, maybe feeding, daily hands-on care for nutrition and hygiene, et cetera, and mobility. Whereas assisted living facilities are really more of a home-like environment that have housekeeping and group dining and activities. And typically residents in this type of community require some personal care or supervision, but they're typically mobile, or even if they need assistive devices, they can usually move themselves real easily out of a chair onto a device or with aids. And typically the way that long assisted living facilities, depending on the type, if it's private versus state funded, are paid for by either long-term care insurance or Medicare. And then there are the acute care and rehab facilities. And these typically, but not always, are in the same building as nursing homes. Thanks, Yvonne, for helping me understand that a little bit better. And so what rehab facilities do is they're step downs from a hospital, typically a short-term stay, and they have a high turnover of patients that are needing acute care. So they're really not needing to be in the hospital, but they need a little bit more care than previously. And in the rehab facilities, there are often, nursing homes often have rehab beds in different numbers, but certainly have rehab patients in many cases that come in. And these typically, depending again on facility, can be mixed with the nursing home residents, and staff move between acute care and long-term care residents. And so the business model in these types of facilities typically is dependent on acute care patients that subsidize long-term care, because Medicare reimburses a higher rate per day for acute care than long-term care. And so this is just the environment under which, much of this type of care is happening. So as we know, residents that are in nursing homes and even assisted living facilities are particularly vulnerable to any infectious disease, whether that's flu or diarrheal diseases, any of them, because they just often have advanced age. So they typically have immune senescence, which means their immune system doesn't function as perfectly as a young person. They frequently have multiple health conditions. That's why they are in one of these types of facilities and residential communities, and they require day-to-day care. So just that in of itself, regardless of what we're talking about, whether it be any kind of infectious disease, these folks are among the most vulnerable of our entire population. And depending again on facilities, residents can share communal spaces. So certainly dining and activity spaces, sometimes bathrooms and sleeping quarters. And depending upon their health status, some people are unable to effectively really understand or monitor their own health or advocate for their own health or be able to participate in risk avoidance behaviors. So think about people, for example, in memory units that are experiencing dementia and really can't really advocate for themselves in a way or really behave in a way that avoids risk. And they have significant vulnerabilities, just health vulnerabilities in advanced stage. Now, remember that also the staff are also part of the equation, and the care for most of these individuals is provided by nurse aides, primarily the direct patient care. And these folks are essential workers, frequently paid minimum wage and frequently not having any sick leave or insurance. And the population of nurse aides is often comprised of, depending on where you live in the country, of non-white, lower income individuals who may share similar social vulnerabilities that put themselves at higher risk for developing COVID. So for example, they may be dependent on public transportation to get to work. They often have caregiving responsibilities for extended families. And these are hard workers. These are people that love these residents, that care for them, and they're reluctant to stay home if they're sick because they understand that they have responsibilities to take care of the people that they really, care for. So I'm going to turn back the clock now to early March of 2020, and this was when the first SARS-CoV-2 case was reported in Colorado. And right around that same time, based upon public health guidance, senior living communities discontinued visitors. And at the time, remember, there was the CDC guidance that all staff be screened daily for COVID-19 symptoms. And the screening at that time was to screen them for fever, for any signs of cough, for recent travel, or known exposure to a COVID case. But recall that back in March, there were 0 tests. I mean, the only tests that were available were for hospitalized patients, and even that was very scarce. So unless you were extremely ill and put in the hospital, it was impossible to get tested for COVID at that time. Now, if you think about what the view was like from the inside, this was just a scramble, because remember that many of the long-term care facilities did not have enough PPE, and PPE was scarce and they were having trouble sourcing it. And so we heard stories about people using trash bags as gowns and the same surgical masks for a week and same gown from room to room. Not only that, but each facility was getting very contradictory guidance from local, state, and federal regulatory bodies, which frequently did not align at all. And they were subjected to severe fines and penalties at that time, again, for infection controls guidance that was actually conflicting between different regulatory bodies in a climate where they didn't have enough PPE, and they were scrambling like everybody to try to find this. There was no test availability. At the time, there was no real guidance as to how to cohort or isolate infected from non-infected residents. And residents, when it was possible, were locked in their rooms, and this was very difficult for them. They were experiencing weight loss and worsening dementia, and staff were doing the best they could to continue that social interaction as they could with the guidance that they were given. But it was really difficult on both sides. Not only that, but the staff who were coming to work to show up and care for these people were afraid for themselves, and they were afraid for their own families. They were very concerned for their residents, and they did not have enough resources to protect them. And they were traumatized by the number of deaths they were seeing. So this was nationwide, not to mention the fact that the media really villainized long-term care facility staff, whereas hospital workers were touted as heroes, long-term care facility staff were actually villainized. So imagine the trauma that was happening on the inside. We became involved in the early effort to test for COVID in these facilities as part of a research project, actually, is how it started. And one person heard about this. This was an anonymous letter that I received from, it was an email from a long-term care facility staff member, not from any of the facilities that we were involved with testing, but this person wrote and said, and they wanted to remain anonymous. They said, I don't want to give details of where I work, but I would like to tell you what we're facing. We've had people die of respiratory problems, but they were never tested. That was because there was no testing. We've had ill staff and ill residents that were not meeting criteria to be tested, or they were sick before testing was even available. Residents are always, many of them are on round the clock Tylenol, so monitoring for fever almost becomes a silly thing to do. So this woman said, I pre-grieve and think it's just a matter of time before we see 20% of our residents die. The residents and their families are suffering because of the separation while we wait for the virus to come knocking on our door. I want to know I'm safe. I want the testing in my facility. Our facility needs it badly. Please don't use my name. Just have us tested, which broke my heart because everybody was scared. And what people were trying to do is the best they could with the limited resources they had. And they were terrified. And, it was a real dilemma in the beginning of this. Now, from within CSU, we sort of thought, well, here are some ideas. We have sort of the resources to maybe help in this effort. Now, remember that at this time, this was early in March of 2020, testing, screening healthy people for COVID was nowhere on the horizon. Nobody was really talking about that. We were starting to understand the absolute threat that this would be to older adults. We didn't have testing resources, and screening was, again, limited to temperature checks and, whether you traveled or not or had a cough. So we at CSU recognized that we have an untapped resource that we might be able to bring to bear on this public health emergency, specifically to help workers and residents in long-term care facilities where there were no resources available at that time. So we realized, this is PCR testing. This is not rocket science. I mean, we do a lot of PCR testing in our normal research lives. We just don't normally test for COVID. And that we actually could scale up and operationalize testing through CSU research labs. We could do it quickly and inexpensively if we could do it without having to be CLIA certified. In other words, without having to have the regulatory approval to do diagnostic testing in people, like a regular diagnostic lab. But if we could do it through a research effort, and we could validate those test results in a CLIA approved lab, we could bring a lot of resources to the table. And the problem was that we didn't really have permission to do that. Regulatory wise, it wasn't permitted. So this was before CLIA waivers, and it was before the EUAs where the sort of regulations around that got a little bit less strict. And then thankfully, the Center for Healthy Aging here had already established relationships in long-term care facilities. We already had trust built up in those areas. And so we were hopeful that perhaps we could do this as a research effort, but really with the hope that we'd be able to bring some type of mitigation strategy to help protect both residents and workers in long-term care facilities. But like everybody, we were faced with severe supply chain issues. So remember that the only FDA approved test at this time back in March was through the CDC, and the CDC FDA approved test has only one type of swab, one particular manufacturer of the plastics that are needed to test, and even the primers and all the different materials that you use to do a PCR test. There was one manufacturer that was the only one that was approved, and we couldn't get them. Nobody could get that material, but we had all different kinds of material. We could use other plastics. We could use other types of swabs. We could make our own primers. We knew that we could do this. The problem was that wouldn't have been compliant with the regulations at the time, because again, we were not a CLIA certified lab and we were going to use non-approved materials. So we asked Governor Paulus if he would authorize a special letter of assurance and issue that for our research efforts to provide situational awareness during a crisis that threatens public health. And at that time, and to this day, the state governors were given pretty broad authority to allow this kind of thing. And we said, we'll do it with under a research effort. We'll have it validated at 2 other labs, but we think we can help. And would you let us do it? And he said yes, which was really pretty remarkable. So at that time, remember, throughout the country, we were hearing about the deaths accumulating. We had no funding for this. We had no funding, but we knew that it was urgent, and we were really very motivated to try to help in this effort. Remember that also that all research at CSU that was considered non-essential, meaning wasn't either COVID related or somehow essential in some other way, was completely shut down. But what we did is we redirected our own funds. From the Columbine Health System Center for Healthy Aging, Dr. Ebel brought some of his lab funding. We passed the hat to the different deans around the school. We even crowdsourced fund this. And literally, we had people whose own research had been sidelined volunteer their grad students to run the PCR. Their postdocs, grad students volunteered to be couriers from bringing testing supplies to different facilities and bringing them back to CSU. And we literally just bootstrapped this thing from scratch and $0, and we got started. And we said, we'll figure out how to pay for it later. We think we can save lives. So what we did is, this is the initial pilot project. So this was the one that we did through a research effort, is we recruited 542 apparently healthy skilled nursing facility staff from 6 different facilities. And they had to consent to be swabbed at least for 6 weeks, at least weekly for at least 8 weeks. So they had to agree to be in the study for that period of time. To be entered in the study, they had to have no reported COVID-19 symptoms. So they had to be healthy. They had to have no known exposure and at least consent to let us do the swabbing. If any of them turned out to be RT-PCR positive for COVID, then the workers agreed to self-isolate and continue to be tested weekly within the study. And if we did detect any positive PCRs at that time, what we did is confirm it by 2 independent labs, and we were required to report that to public health officials. So we made this all this knowledge available to the different facilities that participated in the study, and we asked them would they be willing to do it. And we had 6 facilities that said yes, and within those 6 facilities, there were 542 people that agreed to be in the study. So we were really very thankful for people's generosity in terms of participating. Well, what did we find? Again, this was early in the pandemic, so people really didn't know anything about asymptomatic infection. And what we learned is that 16% of the 542 apparently healthy staff were positive for SARS-CoV-2. These folks were coming to work every day, doing the best that they could, showing up, and yet they themselves had the virus. What was really fascinating about this also was that the people that were positive were asymmetrically distributed across facilities. So we had some facilities that were negative the whole 8 weeks, and then we had other facilities that were, had a high percentage of their staff that were positive even at the start of the study. And then we also looked at job codes just to see kind of what was the job code associated with the highest percentage of positive people that were asymptomatic. And we expected that, yes, we would probably see people that did direct care to be the highest number of percent positive, and true that was the case. Anybody involved in direct care, like nurses or nursing staff, were the highest group. But what was really interesting is that we saw this across the board. There wasn't like any one area that was, kind of not represented within these positive asymptomatic people. So that was really fascinating. We had one facility where, 60% of their maintenance staff were positive. So again, it really didn't depend on whether we were just at this time testing staff, not residents. So it didn't really depend though, whether they had direct contact with patients or not, or residents. It was across the board. And so that was the first that anybody had really identified that there were such a thing as asymptomatic infected people. What was really interesting too is that we had really different incidence. So the number of infected individuals within a facility were different among different facilities. So let's just focus on panels B and C here. These are just data that from that study. So site A through site F, you can see site A stayed negative the whole time, whereas poor site D was pretty highly positive, a very high percentage. By the second week, we're testing 30% of those people healthy, asymptomatic, showing up for work were actually positive. But the other thing, if you look down at panel C that we could show is that once we identified those positive people, we could bring the number of new positives down. So not only did we show that there was asymptomatic positive people, but that by identifying them early and isolating them early, in other words, having them stay home from work, actually mitigated the number of new infections over time. So that was a pretty big finding. And again, very early, before even like CMS or the public health guidance had advised everyone to be testing regularly. The other thing that was, I won't go through the data in great detail here, but the other thing that these data represent was the fact that for a while people were saying, well, if you're asymptomatic, it's very unlikely that you have enough virus to actually infect others. And this was, again, something we showed not to be true. So what we did is we looked at the number of RNA copies, so the number of virus particles that people had in their noses on the swab, and we actually put them on cultures so that we could see whether or not they actually could infect new people. And you can see there's this linear distribution or linear correlation between the number of copies of the RNA or the copies of the virus genome that people had and whether or not they could infect people. So you can certainly see that these are asymptomatic people, and these data show that certainly those asymptomatic people could still infect naive people that had not been exposed. The other thing that we learned from this study was that the natural history of the infection was really very variable. So what these show here in panel A are people that were positive. So this little dotted line is the under the limit of detection for PCR. So people that were positive for 1 week, and then people that were positive for 2 weeks. We had people that were positive for 3 weeks. And this is again, staff, apparently healthy staff. And then we had staff that were positive for longer than 3 weeks. Then we had some staff that actually were positive and then fell below that minimum detection level and then popped up as so they were negative for a week or two and then popped up as positive again. So here's a positive, they were negative for 2 weeks, then positive, then negative, negative, negative. So this is unlike any other virus that we've really dealt with before. And so it really does explain a lot of the reasons why people have been scrambling to understand the natural behavior of this virus. It's extremely unpredictable. This type of pattern doesn't happen with flu or other things. This is a very different virus. The other thing we did is we actually did genome sequencing. And what that is we actually look at the sequence within the genome to look for whether within a facility, the different infections or positives were actually related to one another, or were they just community infections that came in? So the idea here was to see whether or not people were actually getting infected or infecting other people at work, or was it just that they lived in a community where there was a high rate of infection? So if you had a different community infections that were coming into these facilities among these workers, what you'd expect is for a lot of the genomes of the virus to be unrelated. Whereas if it was happening within the workplace where one person was infecting another staff member within the workplace, you'd expect them to be related. And so these colors on this tree represent the different facilities. So this is, remember, site D, the one that had a lot of people infected in the beginning. And what you see, this is just an example of this, is that these genomes were very clustered tightly within facility, which means that it was much more likely that each of these are individual people that were infected, that these people were more likely to have been infected by somebody else working in the facility than they were from the outside community. So that what transmission was happening inside the facility, it was happening from community introductions, but it was more common that it was happening from worker to worker. And then we looked at a couple of different, we had 2 facilities that allowed us to collect blood along with their nasal swabs. And what you can see here is one facility, which is site A, which is represented by the green dots, they were pretty much negative throughout the whole time we were testing. So the green dots show times where we were testing them for COVID. And then site B, which had at one point about a little bit lower than 20% of their staff were positive. And so we actually collected blood from both site A and site B to see what was going on with their antibody response. And what we learned which was site A, which we thought was extremely lucky at the time we did the study, that they had no infection in their facility for their entire 8 weeks. What we found is that roughly about 50% of their staff already had antibodies to SARS-CoV-2, which means that at some point prior to us starting that surveillance testing, they had an outbreak, but they didn't know it. Now, they still had a lot of, the gray here shows people that didn't have antibodies that were in, so there was 88 staff that tested, 90 staff, et cetera, that we took blood from. So these gray ones are the ones that didn't have any antibodies, but really explains a little bit about why we didn't see any new infection in that facility over those 8 weeks, which was really interesting. Whereas site B, which had the really high number of staff that were infected, started with a relatively low number of people that had antibodies, and then that gradually went up. But the point that I wanted to make here was that there was still a ton of vulnerable people. In other words, staff that didn't have antibodies that were susceptible to becoming infected in the setting of a workplace outbreak. So it was an interesting finding that site A had already had an outbreak, but didn't even know about it, which was really fascinating to us. So what we learned from this early work was that about 16% of staff that were apparently healthy and they were reporting to work were positive for the virus, that we could actually isolate infectious virus from asymptomatic individuals, that early identification and isolation of staff led to earlier outbreak resolution, and that when we did the genome sequencing for the virus, it really strongly suggested that transmission within facility was more common than multiple import events from the community. And so those just gives us a lot of information about, okay, how do we then use this information to move forward with helping, predict what may happen in the future, as well as what happens if we have another pandemic, which most infectious disease experts agree is likely to happen even within our lifetimes, to have another pandemic. And so eventually what happened was, as a result of these findings, this early data that we were able to collect, the CDPHE, which is our Colorado Department of Public Health and Environment, and later the CMS, Centers for Medicaid and Medicare Services, adopted the surveillance testing for all skilled nursing and assisted living facilities. So again, weekly testing that was based on our data. And the state was provided another 13, finally provided funding for us to do this. So 13 million in funding, that's actually ongoing now. We're continuing to expand and continue that project. We also have acquired a very large bioarchive of longitudinal samples that were collected from over 8,000 individuals now for almost 72 weeks. So this is, as we understand, the largest longitudinal collection of nasal swabs in the pandemic anywhere in the world. And so that's got some very cool research implications that we can hopefully contribute to the body of knowledge surrounding how the outbreak has evolved and how it's changed over time. We have samples from positive individuals both before their infection, during and after their infection, and then associated data that goes along with those different individuals. We have a bunch of follow-on projects that have been funded, and these just list kind of where that data and where those projects are heading right now. And we've had a number of different publications as a result of it. One of which was a modeling technique that modeling tool that we developed. So this was developed with the help of Bailey Fosnick and Jude Bayham, who are professors at CSU who do a lot of modeling work and statistics. And they developed an agent-based modeling tool to predict outcomes. And what they were trying to do is help us understand what will happen as people become vaccinated, what happens if you use different test types, different sensitivities and specificities. What about the length in days that it takes to get your test results back? Does that influence, whether or not you can use surveillance testing to better prevent infection, and then how often do you need to test. And so what this is an actual free tool. This is the link here, where you can go online and actually use this and model your own situation. So we really kind of directed this for people that worked in long-term care facilities or public health officials to sort of plug in numbers and then have the model actually predict what might happen. So let's just say in the case of this facility, there's 125 day staff, 45 night staff, and there's 90 residents. And then you can have starting conditions like the initial infected staff. So these would be people that you didn't know were infected that come in. And then let's just say we have a percent of 91% vaccinated in your staff and 78% vaccinated in residents. And we're doing PCR tests, and we expect that to take 2 days, and we're to come back, and then we're doing it weekly. And then it shows you a whole bunch of different parameters, and eventually comes up with an output of how many cumulative infections you will have over it looks like, yeah, a 20-day period. So 22 new infections, and how many worker days would need to be missed. So by isolating those people. So it's kind of a way to help figure out how you can best utilize resources to, understand a little bit more about how to use tests. The big thing is that when surveillance testing was finally sort of supported by everyone nationwide, the kind of surveillance mitigation testing that they were doing really didn't take into account the sensitivity and specificity of the different test types and the turnaround time. So using this, they were able to really see how, if you test weekly versus, every 2 weeks, or if you test weekly, but you're not getting your test results back until 3 days, how all those different variables would really affect how effective your mitigation strategy was. And that paper has been submitted for publication, so hopefully will be out soon. So what have we learned? Well, we've learned that infection control is always going to be challenging in long-term care facilities, and there are things that we'll never be able to control. For example, we can't control the advanced age and the comorbidities and the general vulnerability of these people to any infectious disease, but we can prepare better. Worldwide, to have access to PPE. We can utilize surveillance measures much earlier than it was utilized. I think we were able to show how helpful that is. You can cohort residents, in other words, separating infected and non-infected residents with understanding how any kind of contagion is actually passed along. So if it's a respiratory virus versus something else, those kind of indicate different types of isolation techniques. We can design facilities that help mitigate the potential for airflow, contamination, et cetera. And we learned, that the long-term care workforce is really fragile, and we need to help protect that, and we need to help prevent them from having staffing shortages. And by stronger regulations and, I guess poorly thought out kinds of measures don't help them, because what it does is limit them. So we need to really follow the science and help us understand how best to help them. And then we can engage them in studies. Certainly there was a bit of a hurdle initially. It was just engaging the long-term care facility workforce, just because they were so stressed and trying to respond so quickly to these changing situations. So we're really, really thankful and grateful that the facilities that participated in this early study were letting us do this with them, even in the midst of a crisis. And that we need to, again, initiate surveillance earlier and adapt to the changing science. We've also learned that, models of care and reimbursement need reform, that it would be really important to help have pay and benefits that for care staff, that these essential workers are extremely valuable to us, and we need to make sure that they're compensated in a way that really takes into account the #1 risk and the dedication that they have to their residents. Home-based services and other alternatives to help people understand what that might look like. Being able to separate acute care and long-term care facilities. Medicaid reimbursement strategies, changing and reforming those. Designing physical facilities to facilitate response to potential contagions. Again, are there ways that you can separate off rooms or different areas so that there isn't a lot of cross-contamination? And finally, and this is where CSU can really be of help, is employing technology for environmental and health monitoring. So things like wastewater testing. We know that if we can look in wastewater that comes from a building, we can detect signals for example, for COVID long before we can actually detect them by PCR. So it's extremely sensitive. Wearables, so helping, understanding when people have spikes in temperatures and being able to investigate that. Machine learning algorithms that help us understand, hey, there's something that's happening in this facility that may not be normal, and computers sort of analyzing a lot of different inputs and is able to say, hey, maybe you should check this out, something's not right. There's a lot of technology, I think, that could be utilized to help. And we're learning as we go. So I've been really proud of the CSU group for, thinking about this and really bringing this to the spotlight. And certainly, while the process of sort of reform and helping to utilize technology to better protect both staff and residents in long-term care facilities, it's slow and cumbersome. It's like turning the Titanic, right? But the good news is that now we know the icebergs are there, that we are going to encounter more of them. We're still in the middle of this pandemic. It's not over yet. The question is whether we can still turn the Titanic in time to prevent, another tragedy. And maybe this ongoing effort that we have is going to shed enough light on the system and bring enough attention and bring to bear the mind bank of CSU and other scientists in the scientific community to really make a difference and really change the outcome for the future. So with that, I want to give great gratitude for my collaborators who are listed here, my co-PIs, again, Christy Pavoloni and Greg Ebel, and the many people in the community and within the CSU community that helped, including Columbine Health Systems, Vivage Living Communities, Rehab and Nursing Center of the Rockies, and certainly the countless nurses, aides, and families and residents of long-term care facilities who were kind enough to help us with, getting this project off the ground. So deep, deep gratitude to all of those people, and we couldn't have done it without you. So I will stop there and see if you all have any questions.
Thank you, Nicole. If anybody has questions, feel free to unmute or pop them in the chat.
I will say that it was a real chaotic time because, there was a lot of question about whether we were even permitted to be doing this type of testing. And there was, concerns from the university as to how legal all this was. But thankfully, because of Governor Paulus's letter of assurance, we were covered and we were able to do that. And it turned out that it contributed to a really pretty important effort nationwide. So I'm really thankful for that, for that belief in us in the early days of the pandemic.
Getting a lot of love and appreciation in the chat. I did have a question for you though. What are some of the ways you think we could address potential future shortages in nursing staff in long-term care facilities? Do you think it's just an education thing or lack of appreciation and benefits?
Yeah, well, I think it's a multifactorial issue, and it is a crisis right now in and of itself in long-term care is, attracting staff to that field. I think that, so as a university, I think that we can do a lot in terms of making those kinds of trainings and, encouraging people to consider careers in that area, regardless of whether they're, direct care individuals, so people that would ultimately become nurse aides or nurse practitioners, et cetera, or, physicians. And with the launch of the new medical school here on CSU's campus, one of our plans as a center is to really engage that medical student class in different types of capstone projects so that we can really introduce to them the opportunities that exist in aging and in gerontology, as well as, physician scientists, trying to help them, engage them in clinical research that I think will benefit this whole demographic. And it's a very complex picture. I won't propose to know all of the ins and outs, but I've certainly become a quick learner about what the, kind of where the problems are and challenges are. So I certainly think there's a lot that CSU can do to continue to be involved and continue to attract people to this field. And it's certainly an area where I don't, it's never going to get smaller. It's only going to be a greater need as we go toward the future, because more and more people are aging and living longer. So I think we're well set and poised to be able to be a leader in that space and helping people come to that area. So thanks for that question, Allie.
Would definitely agree. I think a lot of people underestimate the benefits just in knowledge and, knowing you're making a difference by working with older adults.
Yeah, and I think that the reward, even how I feel, which was again organizing and launching this big effort. Hi, Barry. The reward of working with the CSU community and how people pivoted and literally like volunteered their time, their lab resources. It was one of the most rewarding things I've ever been involved with in my career. I mean, it was truly heartwarming to see how much people cared and what they were willing to do just to try to help. So I was really proud of us. I'm really proud of that community. Hi, Barry.
So I do have a question, Nicole.
Yes.
So thanks, that's incredibly interesting. And I'm, familiar with some of the projects, and it was just a heroic effort all around. But I've just been looking at what looks like the contrast between the transmission in the facilities, which you tracked in a really sophisticated way, and the transmission on campus, which, we did it in a much less sophisticated way, based on contact tracing, not on, heterogeneity in the virus. But it looks like we didn't have a lot in the classrooms amongst ourselves. We didn't really pass it around. And, it's a younger population, so there's that. But what else? I mean, do you think we just missed a lot of it? Did we just get lucky? What do you think?
Well, it was really interesting because we actually didn't start saliva surveillance we started our surveillance in March. I think it came online January of 21, right? So we probably had more than we thought we did, number one. But the other thing that, was happening was the wastewater surveillance. And so Carol Willits and others who were really on top of that whole technology and how to predict. And so it would be like targeted surveillance testing for, if you had a dorm that had a wastewater signal, then you would go in and test all of those students and staff in that dorm. But you're right, it was remarkably less so here, but that's true across the nation in terms of, if you look at long-term care facilities and the rate of transmission and the rate of, morbidity, mortality, much, much higher than the average community. So we are more like an average community, and we do have a younger population. And now, thankfully, that most of you know that we have like 95% vaccine compliance as part of our, community. So that's really helping and definitely made a difference this year. So yeah, you're right. I mean, it is there, it just points to the fact that, people, residents within these long-term care facilities are particularly vulnerable. And that staff that work there, it's a high-risk job because you're working in a high-risk environment. And really those staff are not really properly, I can't say this because I'm not an employer of them, but it seems to me that compensation should be, kind of commensurate with that risk and their need.
Thank you.
Yeah, thank you.
Anyone is welcome to pop on screen or ask a question if you'd like.
Well, thanks. It was kind of a home crowd, but I was really, really grateful that you all came to hear it. I appreciate it. Please don't hesitate to reach out if there's anything we can do to, clarify anything. And we're more than happy to share samples and share research ideas and continue the dialogue about this, because I think this is a really important issue that's not going to go away, and we need to continue to shed light on our communities that care for these folks that are super vulnerable. So thanks to everyone.
1 second, we got a last minute question in. Thanks, Lene. How can we share this info with the public so they trust science? Yeah,
I mean, it's really a weird climate right now in terms of how the public is receiving their science information. And it's my opinion that the media is not the best source, because it, the way in which most people are consuming kind of the latest information about, for example, the pandemic, is really based upon how the media has spun something. And you can find very conflicting and confusing information out there, as well as really kind of focusing on very small pieces, but not really looking at the whole picture kind of problem. It's been a great frustration to me, Lene, and also the idea that because of that, it's really caused there to be a loss of credibility among the public towards science, because to them, it looks highly contradictory and highly inflammatory. And, you can create a lot of emotional response with how you do headlines, etc. One thing that that someone said recently who studies science communication, so this is a person who that's their expertise here at CSU, said that the interesting thing is that most of the time prior to the pandemic, the public was used to kind of being presented with science once it was concluded. So once things, sort of were, well proven, easily repeatable, and then they'd get this kind of chunk of information that would be about that particular discovery or finding or whatever. This is probably the first time where worldwide the public has been exposed to science as it evolves. Those of us who are scientists understand that science is always evolving and we're always using corrective science. So as more information is known, we sort of can hone in on predictions or facts. What we can do before that is known is say, based on what we know so far, this is what we think is most likely, or this is what we think is correct. And then as more information comes in, we begin to get better and better at being extremely accurate about that. But the public has not really experienced that process, the scientific process that evolves over time, so real time as it has during the pandemic. And I think it's really, there's been a lot of very interesting responses to that, some of which is anger and loss of feeling like science is credible. And so I think you bring up a really good point, which is that those of us who are involved in education and those of us who have any kind of platform where we can interact with the public really need to help people get a more deeper understanding of that this is not an unusual situation in terms of how science evolves, but help them understand how to find credible sources. So I really do appreciate that question. It's a question that I don't have the answer to, other than to continue to help educate people. And those that really want to learn and listen will, and those that really don't, we're not going to change their opinions. So it's a sad outcome in some ways from what we've experienced now. And I think the media has certainly not been our friend in terms of helping get accurate information out widely. They're more interested in the emotional response to the headline. Yeah, she says, how about teaching science differently in public schools? I mean, I think that helping students understand the scientific process is part of that. And I'm not a school teacher, so I can't really share, or I don't really have any expertise on how things are being presented in public schools, but certainly starting with that. And I mean, this will be a great case study to think about in public schools. Like this is, this was the public response. So I agree that we can use these as very important and effective learning tools.
And I would also say, for a little shameless self-promotion, that you can always send friends and family our COVID-19 expert panels, which are all located at the link in the chat.
Yes, thank you, Allie. And continue to come back to our website, Healthy Aging at collegestate.edu, because that's where we have the latest and greatest for aging research. And we're absolutely involved in making sure that you get the best information and the most accurate information that we have.